So for patients who have early stage hormone receptor positive breast cancer, a fundamental part of treatment is adjuvant endocrine therapy. This means taking medicines to block our body's own hormones from stimulating any residual cancer cells. These include oral medicines such as tamoxifen or aromatase inhibitors, and importantly for our younger patients, this might include taking medicines to purposefully put someone into menopause state. And so nowadays, that's all very fundamental part of treatment. Much of the work that's being done is learning how we can add on top of that to improve how people do and help them do better. Adjuvant systemic therapy is designed to travel throughout the entire body, and if there are hidden cancer cells or cancer cells left behind after initial treatment with surgery and radiation, the systemic therapy is designed to find those cells and try to kill them so they never come back. The primary modality that we use for hormone receptor positive disease is adjuvant endocrine therapy, so taking medicines that block our body's hormones from stimulating cancer cells. Some patients may also receive chemotherapy, although not everybody, and we're very careful when we make those decisions about which patients are best suited for chemotherapy. When we think about what types of treatments to offer for patients, we want to consider a variety of factors. We want to think about the cancer stage, meaning how large is the cancer, has it gotten into lymph nodes. We want to think about the tumor biology, and that includes the hormone receptor status, the grade, thinking about what's driving the cancer cell, what's making it grow. And then the third feature we want to think about is who is the person with breast cancer? What's their health like? Do they have other competing health issues? And really importantly, what are someone's preferences? What do they want to receive in terms of their treatment? And this is the work that the breast cancer specialist does with the patient to help come up with a personalized treatment plan. So I'm really excited to speak at this meeting about some of the new therapies that we have available for hormone receptor positive disease. One of the most important is a category of medicines called CDK4/6 inhibitors. These are pill medicines that are targeted. They're not chemotherapy, they're not hormones, but they're their own special category. And they are designed to be used in combination with hormone medicines to help them do better. These are medicines that we use quite frequently if patients have recurrent metastatic breast cancer. And the idea is to use them earlier on in treatment to help prevent cancer from coming back and help cure a patient of breast cancer. Currently, there is one medicine that's been approved in the United States called abemaciclib that is in frequent use for high-risk node-positive, hormone receptor-positive disease. And there's been a lot of research looking at other agents which may also have benefit in this setting. So I'm excited to cover this topic and talk about new directions. Another topic we're going to talk about is the use of immunotherapy for hormone receptor positive disease. This is a very specialized kind of medicine designed to stimulate our body's own immune system to help fight the breast cancer. And we use this quite frequently for patients who have a different kind of breast cancer called triple negative. We give this before surgery. There's been some very provocative data coming out in the past year looking at trying this strategy for hormone receptor positive. And we're going to think about how this might work and who this might be best for. So a lot of research, a lot of new discovery. I think it's going to really revolutionize how we take care of patients in this space. So I think for someone who's been diagnosed with early stage breast cancer, one of the most important things first is having a good relationship with your providers. Breast cancer teams around the world are so highly trained, and we work together as a global community to provide the best possible care for patients. And so being comfortable asking questions, and if you hear about something or read about something, bring it up with your provider, see what they think, bounce it off them. I think that's really important. Also, none of the work we have available today, none of the important tools would exist without patients volunteering to be part of clinical trials. Participating in trials is an immensely important way to help move the needle forward with how we take care of breast cancer patients. So I really encourage people to ask about being part of research. I would say one of the most exciting things that's happened in the world of hormone receptor positive early breast cancer over the past couple decades has been the use of genomic tools. We have a test called Oncotype, which is a test done on tumor tissue that's removed either with biopsy or at time of surgery. This test is really important because not only does it give us a little insight into the breast cancer tumor biology, but it also teaches us about whether a cancer is sensitive or not sensitive to chemotherapy. Not every cancer responds to chemotherapy. Not every cancer is sensitive. And we certainly don't want to give that to somebody if it's not going to help them. And so for the vast majority of people who are diagnosed with hormone receptor positive breast cancer, we do send these types of tests. And this really helps us better understand and select who are the people for whom chemotherapy will be helpful and they should go for it, and then who doesn't need it, who can be spared that exposure. We want to offer the right therapy for the right patient, and tests like Oncotype have helped us get there. It's incredibly gratifying to meet with my colleagues who work in places all over the world and find that our treatment patterns and our treatment decisions are very consistent. The way we take care of breast cancer in Sydney is very similar to how we take care of breast cancer in Boston or Vienna or London or anywhere. And so this is very helpful because this means that we can run global clinical trials knowing that we can improve the standard of care in all of these places around the world. And I think that also provides a lot of confidence for patients that no matter where you are, anywhere in the world, your doctors talk to other doctors in other countries, they attend international meetings, and the decisions that are made are decisions that are not specific to your clinic or your country, but these are the decisions that women around the world are making together. So I think I'm very much reminded of that when I come to visit with my colleagues, and I'm really just gratified for our international community.